Hi, everybody. I am going to give a few minutes for everybody to get in. And one of the things that I wanted to bring up while we're waiting is that the final rule came out yesterday. So, as a little bonus, I had a couple little things that I'm going to show before I talk about the OIG and telehealth so that everybody can kind of start looking at what the final rule is saying. So again, the conversion factor, as usual, has taken a hit. So we'll have to see what happens in Congress about that if they do our little kind of saving thing at the end of the year to get our conversion factor up a little bit more. But if not, it has taken a little bit of a hit this year, down about, I think it was like $1.67. They lowered the conversion factor. So that was one thing that was kind of interesting. So I'm going to share my screen here and show a couple things on that before I bring up the presentation for today. So let me share my screen. And as y'all come in, if you could please, in the comments, just give me a little hi and let me know that you're here so I know that, we're getting enough people in for me to start the main presentation. So let me share. All right. So what I have first up on the screen is the actual final rule. And as you can see over here, it is 2,414 pages. So as usual, it's a whopper. Um, I haven't had a chance to go through all of it yet. As I said, it just came out, but I know what I'm going to be doing this weekend. So as you can see here, they go through and they give us a nice little summary as they usually do. And after we get through everybody that had a piece in making it. But what is good, I think they always give us our executive summary, but if I made a post on this, I believe yesterday also, that here in the cms.gov newsroom, they also put up the highlights kind of the final rule. So talks about, of course, the background. They always give that because they like to give the historical factors before they start in and give us information on what they're, going to tell us. But they talked about here's the conversion factor issue. And as you can see, the factor is going to drop down to $33.59, which is a decrease of $1.30. Sorry, I was off a little bit of from the $34.89 that it was set at this year. But then it talks about E&M and that they are still reviewing the payments for E&M visit code sets, and that they finalized those new changes that took effect at the beginning of this year. You can kind of see how that's been weighing out for you by doing some reports and seeing your E&M utilizations and kind of track how you're doing with that. I did either a broadcast on that or a couple posts and article for that too, that you might want to be looking for. But then it goes in, they had a section this year in the final rule on split shared visits to refine what their policies were for split shared. So you've got some information on that. Critical care services, you've got some more information on that. Path services, they went back through and finalized and clarified what time can be used to select your levels of E&M. And then there was also a big section on telehealth, which kind of leads into our talk today about telehealth and the OIG. So if you're involved in telehealth, as Karen, who sent me a message already, said that she was doing some telehealth work, you'll want to take a look at this and see where CMS is finalizing how they're extending things. Now they're going to extend through the end of the year 2023 the inclusion of the telehealth services lists for those that were added temporarily that would have otherwise gotten removed, so that they can kind of keep evaluating them to see if they need to add them permanently, and also to give people a chance to transition back out of not being able to use them as they are now, if they don't add them permanently to the list. And then they also have a highlight here on therapy services and PA. What I thought was interesting there, and again, I haven't read through the whole final rule yet, is that they are implementing authorization for PAs to form groups on their own, get their own uh, billing numbers, and be able to bill Medicare as standalone. So you may see some PA groups forming and billing services to Medicare without having to have supervision for their professional services. So that could be very, very interesting, something that I think I'm going to, keep an eye on too, to see what's going on with that. They also have a vaccine administration services section that they highlighted here, and MNT for nutrition therapy, and co-insurances for colorectal cancer screenings, opioid treatments, rural health clinics. They have a nice big section on here, the FQHC payments and electronic prescribing for controlled substances, certain manufacturers reporting drug pricing information, ASPs, Part B drug payment sections, CLIA clinical lab fee schedules, and appropriate use criteria, pulmonary rehab, the Medicare Shared Savings Program, and updates and payments for financial transparency, and provider enrollment, their ground ambulance data collection system. So those are the things that CMS has highlighted in their report out to things that were big changes or big additions into what they were looking at for the final rule. So I also, in the comments, have also added in the links to the final rule and to this document that I have up right now from the newsroom from cms.gov, so that you could go ahead and take a look at those things and see, what kind of applies to your practices, so that you can kind of dig into that more instead of trying to wade through that almost 2,500 page document, because that is no fun. But that's what I will be doing myself all weekend. So I'm looking over here at my comments, and oh, hi, Jerry. How are you? I hope you're doing well. Good to see you. Catherine, thank you. Oh, and you're quite welcome. I'm glad to, be of some service. So let me go ahead and pull up the presentation for today. Sorry, that was my dogs. All right. So what we're going to take a look at today is, as I said, was telehealth and the OIG. As the pandemic has come and CMS relaxed some of the rules and things that are, surrounding telehealth, of course, because of the increase in use, anytime we have something like that, the OIG, the Office of the Inspector General, wants to take a look at things to make sure that everything is being done according to the guidelines and the rules and the requirements that are set out. So currently there are 7 telehealth projects on the OIG work plan. There was one that was on there and they recently made findings for it. So I'm also going to show you what that looks like when they put out a report. So with the OIG, or the Office of the Inspector General, that was established, back in 1976. And it is the largest Inspector General's office in the federal government. And what they are doing is looking for fraud, waste, and abuse in the Medicare, Medicaid, and more than 100 other departments of DHHS, or the Department of Health and Human Services programs. So their main goals are to, of course, fight fraud, waste, and abuse, also to promote quality, safety, and value, and to advance excellence in innovation. And I got those 3 goals off of the OIG website. So that's what they state their purpose is. So looking at the OIG, there are actually 6 units into the OIG. I just want to make sure that, because a lot of people know what the OIG is by name or by the acronym we use for it, but they don't quite know like how diverse and all the different things they do. So I wanted to just give a little bit of an overview of that so you have a better understanding of those things. So you have the immediate office of the Inspector General, and that office consists of the Inspector General, the Principal Deputy Inspector General, their Chief of Staff, technical advisors, and then other staff. And so the immediate office makes the contacts with Congress, HHS, the public, and they lead the congressional media and public affairs interaction. So it's kind of like their PR department, and that's where the actual Inspector General kind of resides. We also have the Office of Management and Policy, or the OMP, and they formulate and execute the OIG's budget. They develop policies, manage information technology, human resources, executive resources, procurement activities, and the physical space of the OIG. Next, we have the Office of Evaluation and Inspection, the OEI, and they're the ones that conduct the evaluations for the HHS programs and operations, and they and their processes, and they look for vulnerabilities and make recommendations for corrective actions. So when we see the reports come out, we'll see different things on there. And I'll show you in a minute when we go to the actual website and look at where the work plans are listed, you'll start to see some of these things listed. It will show you which one of the units of the OIG is actually putting out that project. So you'll see on it where it'll have OEI or OMP or OAS. So you'll know what department is looking at it. So we also have the Office of Counsel to the Inspector General. And of course, they provide general counsel and legal advice to the OIG itself. A 5th unit is the Office of Audit Services, the OAS, and they're the ones that oversees their audits. They establish their priorities, they perform the audits, they oversee the progress, they coordinate with other stakeholders and recommend changes to program policies, regulations, and legislation in keeping with that goal of preventing fraud, waste, and abuse. And they also improve programs and operations and report on audit impacts. And then finally, we have the Office of Investigations, or the OI, and they take over if the audits lead to investigations by conducting criminal, civil, and administrative investigations. So they will take over when we're looking at cases of, fraud. So for fraud, waste, abuse, mismanagement, or violations of the standards of conduct, and that fall under their jurisdictions. So the OIG work plan, which I think was interesting, it used to come out for those old timers like me. It used to come out once a year at the end of the year for the next year, and the OIG would put out, a big PDF folder, and it would break it down by whether it was hospital or whether it was physician driven or whether, so which area they were looking at, and then it would list what the projects were for the coming year. And if you look at the slide that's on the screen, you can see, the little PDF kind of copy here. And so I remember when it would get near the end of the year, we would all wait for it to come out, and then, we'd download the PDF and have to start digging through it. Well, the OIG has recently, since 2017, they have started to publish it online so that on an ongoing basis, they can add to the work plan and notify everybody of what they're looking at, because there are just so many things that they want to take a look at. they did it this way so that now it's electronic and it's also current time as you take a look. And so you can look at what was recently added for this month, and then what their active projects are, and then look at their archived projects also. So you can kind of go through it that way, which is what we're going to do in just a few minutes. So in looking at the work plan, the OIG says, when they're choosing what they're going to put on the work plan, they look at what are the top challenges that are facing Health and Human Services, other work that the organizations are performing, what previous reports have found and what actions have been taken on those, the mandatory requirements under the law, our regulations, and requests also made by Congress or HHS management or the Office of Management and Budget, the OMB. And what they see is where if they look at something, they can have the best outcomes or the best, biggest impact on something. All right, so now we're going to go over, I'm going to pull that down. And we're going to go back to where I was showing you the screen before, and we're going to take a look at what the OIG work plan things are. So as you can see here, what I did was I pulled up the OIG where the work plans live, and I also put this hyperlink into the comments for you so you can take a look at it. So as you look at this here, you can see where you can go to the work plan home where you can see everything listed out, or you can look at what's recently been added, and that's for the month, or you can look at the active work plans and the archives. So I'm on the active work plan items on the OIG site here, and I put in telehealth in my search. And then it came up and it's showing me all of the telehealth projects. So anytime that the OIG is looking at something and they put it on the work plan, each of these they call a project. So if you are looking for something else, like evaluation and management, you can search for that, and then it will bring up, the E&M things that are being looked at. So you can see here now, one of the bigger issues that just came out was that they're doing an audit for emergency department E&M services. So, and that is currently going on, and that was added just recently. So you can go in there and type for any kind of issue that you're looking for to see if the OIG is also looking at it for some reason and what specifically they're looking at. So as we look at these, this first one, the audit of IHS telehealth technologies, cybersecurity controls, that one was just added. And here it'll tell you this one is being done by the OAS, the Office of Audit Services under the OIG. So that's one of those 6 units that we talked about. And then it'll give you a report number. So when you get here, when you look at all of these, you can just click on it. So we'll click on this first one. And then it will tell you what they're looking at. So it tells you that the pandemic response has included significant increase in use of telehealth technologies. So the dramatic growth in this utilization has introduced new cybersecurity risks to medical facilities, including the Indian Health Services or IHS facilities that use these technologies. So they're going to do an audit to determine whether the Indian Health Service has implemented select cybersecurity controls to protect the telehealth technologies from these cybersecurity risks. So that's what they're looking for. So the agency that they're concentrating on is Indian Health Services for that project. And then here we're looking at the next one is a review of beneficiaries' relationships with providers for telehealth services. This is one that if you're providing telehealth services in your office, you'll want to make sure, that you're following, because as you can see, the OIG is taking a look at this, and this is done from the Office of Evaluation and Inspection, so the OEI. So here, as we know with the telehealth services, that they're looking for a relationship between the patient and the provider prior to telehealth services being performed. So in this project, as you can see on the screen here, that they're saying that Congress and DHHS expanded access to telehealth for a wide range of services. As we know, that list is growing and growing. And the expansion enhanced the ability of healthcare providers to offer care for Medicare beneficiaries remotely during the pandemic. So they're just kind of explaining the broader nature of what they're doing. But during the expansion, HHS used its enforcement discretion to relax the requirement that a beneficiary must have an established relationship with the provider to receive certain telehealth services. So this data snapshot will describe the extent to which Medicare beneficiaries had established relationships with providers from whom they received telehealth services. And they're going to look for any differences in the relationships between traditional Medicare and Medicare Advantage among the different types of telehealth services. So they're just trying to check and see, from a data perspective, how many patients had relationships, how many did not have relationships. So what were the new patient visits coming across from the telehealth visits versus established patients, and what's going on with that relaxation. And I don't know, sometimes when they put these out, you don't know exactly why they're looking at it. And sometimes they make it pretty clear why they're doing it. So I do know that as part of the like the ATA, the American Telehealth Association, and the Interstate Licensure Compact, the ILC, that allows physicians to be licensed for telehealth services in states other than the state that they're licensed to practice medicine in, which is a way that they can expand their services. Doing that, of course, they may see more new patients. And so maybe they're trying to see if after the pandemic's over, do they need to leave, kind of an open door a little bit to have providers and physicians and other providers with the allowance to see new patients by telehealth? Or if there's not a lot of people doing it, is that something that, they can go ahead and, rein back in to where it has to be that you've established a relationship with the provider prior to having telehealth services? You're never quite sure till the report comes out and they give some more information. But that's one of the things they're also looking at also. So here, this was on the list as an active project until just recently. And when they have closed it, you'll notice that it is no longer a hyperlink. So you can't click on it and see what they were looking at. But when you look over here under the column for report numbers, they actually have the reports out. And the OEI at the beginning of it will tell you which unit of the OIG had done this. So you can see that's from the Office of Evaluation and Inspections. So they put out two separate reports on it. So if you click on the first one, it will give you the report there, and it tells you why they did the study. That again, telehealth was an important tool for states to increase access for behavioral health prior to the pandemic. And of course, once the pandemic started, the use of telehealth, has become even more important in addressing behavioral health needs for Medicare enrollees. Because if you look at all the information that's out, there has been a lot of mental health issues that patients have had come up, because of the pandemic. So you're seeing more patients with depression and separation anxiety, general anxiety disorders, all of those types of things. And so they're trying to take a look at, the benefits of having the mental health studies out there for telehealth services. So when you take a look, they'll tell you how they did the study. So they say states commonly provide behavioral health services to Medicaid enrollees through managed care organizations. And they took a survey of state Medicaid directors from 37 states that provide behavioral health services via telehealth through managed care organizations. And then they did structured interviews with some relevant stakeholders. And then they asked about challenges specific to managed care. They also focused on states' challenges with using telehealth just in general. And then they give you what they found. So they said that a lot of states reported multiple challenges with using telehealth, including lack of training for providers and enrollees, limited internet connectivity, which is why, again, you see that national push for the broadband connections and all of that stuff too, to help and assist with being able to offer these telehealth services to more people. Because if you have people that are out in rural areas and they don't have internet connectivity, well, it's going to be kind of hard to provide telehealth services for them. Also, some of the states reported challenges, including lack of licensing reciprocity, so that interstate licensure compact I was talking about, for being able to see patients that are out of state, and difficulties with providers obtaining informed consent from enrollees. So those things limited the state's ability to use telehealth to meet behavioral health needs for Medicare enrollees. And then they give their recommendations. So what they recommend and how the agency responded. So CMS, they're telling you that they have an important role to play in facilitating these things, and to help give information to the states to improve the use of telehealth for behavioral health services. And if they share information better to the states, it will help ensure that the states can realize the benefits of telehealth and make informed decisions about how to address challenges using telehealth. Then they also recommended that CMS share information, as I was saying, to help states address those challenges, including examples from states. And I thought this was an interesting idea, examples from states that describe how they've responded to the challenges. So like look at states who have done it and done it well, and kind of let them give information that can then help other states to be able to do the same thing. And it also said that CMS could collect information from states detailing their experiences and lessons learned in response from COVID-19 that addresses those. And CMS, it gives what they said. So CMS concurred with our one recommendation. So CMS read through the report, read what they said, and said, yeah, these are good ideas. So what CMS does with those, is another story. But with looking at these, you can also see where sometimes you find where CMS will come out with new plans and new projects of their own where they're trying to help. And some of them are based off of these OIG projects where they take a look at them and make recommendations to CMS on how they can help. So the other report was opportunities exist, saying that there are opportunities to strengthen the evaluation and oversight of telehealth for behavioral health in Medicaid. So again, why they did the study, that stuff is pretty much the same as it was in the last report. How they did the study, again, the same thing. What they found here, now they're looking at that most states can identify which services are provided via telehealth. A few reported being unable to, limiting their ability to evaluate and oversee telehealth. So only a few states have evaluated the effects of telehealth in their state. The states that did found increased access and reduced cost, which everybody, most people have been saying all along with getting, on board with having telehealth, getting wider use, is that it could increase access for people that can't travel 200 miles to, see a certain specialist, or have, again, with the mental health issue, have issues with even attempting to get to an office that's near them, because of some of their mental health issues, but reduce the cost because then you don't have all of the overhead of the offices and things like that that you may have to have when you have patients coming in person. And it also goes on to say, based on their own experience, other states believe that telehealth increases access, has uncertain impacts on costs. So some people, because then you also do have to invest in, the proper equipment and things like that for doing telehealth. And you do have to be somewhere when you're giving the service. So after the service, there are still certain things that nursing staff and things like that have to do. So they're like, well, it's not these, huge cost savings that some people have been saying we didn't find as much, or, so it's kind of at that stage now because there's not a whole lot of studies that's been going on as far as that issue goes to say where they've found cost savings or how much they have found. And also some of them raised concerns about quality. Further, despite concerns about fraud, waste, and abuse, many states do not conduct monitoring and oversight specific to telehealth. And that's one of the things in the OIG work plan and the OIG has been putting out. If you've been watching some of the reports that they've been putting out about cases recently that they have brought and fines that they have levied, a lot of them have been against providers that have abused the telehealth services and have used them in very improper ways. And so there are some bad actors out there. And so the OIG is saying, there's a lot of this going on, but we're not finding that the states are really monitoring for that yet. So their recommendations here are that, that the CMS and the state efforts to evaluate and oversee telehealth are critical to meeting Medicaid enrollees' behavioral health needs and safeguarding the Medicaid program, because they want to make sure that the programs can continue to run to help others. And if you have these bad actors out there that are kind of draining resources, that's going to be a problem. So it further goes on to say these efforts are particularly important as the telehealth landscape continues to evolve. So their recommendations for this are that CMS ensures that the states are unable to distinguish telehealth from in-person services, implement indicators to identify which services are provided via telehealth, and also to conduct evaluations and support states' efforts to identify and support states' efforts to evaluate the effects of telehealth on access, cost, and quality of behavioral health services, and to conduct monitoring for fraud, waste, and abuse, and support the state's efforts to oversee telehealth and behavioral health services. So CMS answered back and they said they concurred with the first recommendation, but they did not explicitly indicate whether it concurred with the other two recommendations. So CMS kind of, has kept closed mouth on the issue of conducting monitoring for fraud, waste, and abuse, which I found kind of interesting, because they are really kind of hitting it hard. So, just kind of something to watch for in that one. So other projects that are on are audits of home health services provided as telehealth during COVID-19 public health emergency, audits of Medicare Part B telehealth services during the COVID-19 public health emergency, home health agencies, challenges, and strategies. So we have home health in here a couple of times. Looking at Medicare telehealth services during the COVID-19 pandemic for program integrity risks, the use of Medicare telehealth services during the COVID-19 pandemic, and Medicaid telehealth expansion during COVID-19. So, as you look at these things and go through, they've got quite a few projects in here on telehealth. Now, one of the things that I did get questions on from people was asking about how, let me stop sharing my screen here, was, how are they able to, to do these things? So one of the things that the reasoning behind it is are the 1135 waivers. If you've heard people talking about that, over and over and over again, that due to the 1135 waivers, that's why they can do this and do that. What the 1135 waiver is something that can take effect when the president declares a disaster or an emergency under the Stafford Act or the National Emergencies Act. And then the HHS secretary also declares a PHE, a public health emergency, under Section 319 of the Public Services Act. So when that comes into play, then the secretary is authorized to take actions that are in addition to their normal authorities. And the waivers usually end no later than the termination of the PHE or 60 days from the publication of the waiver. But the secretary also does have the authority to extend the waiver, and they can extend it for additional periods of up to 60 days up to the end of the PHE, which is why you see over and over as everybody talks about, whether or not the PHE is getting extended. It's because it's part of the 1135 waiver that in order for those things to continue to take effect, they have to keep extending it officially with that 60-day time period around it. So that's why you keep seeing that every so many months that they'll come out and say that they're extending the PHE. So in looking at all of these things, and asking, okay, now I see what they're taking a look at. What am I supposed to do about it? So I've got some steps to take that I'll put up on the screen here. So first, what you want to do is, just like we were doing, is read through the current OIG telehealth projects. So see what's out there, see what relates to your practice, choose all projects that then relate to your practice, and then conduct internal audits focused on those projects. So, you can pull out one of them that where they're looking at, the use of telehealth for the established patient issue, and take a look and see how that's going. Take a look at what's in the project and then relate it to what your practice is. Then from there, you want to educate your physicians and other staff on the outcomes of those audits, at what you may be at risk for, or what you need to adjust in order to stay compliant and make sure that there's nothing that's coming your way because of using these. Because what happens, as you can see from that report, is that the OIG will do these projects, they'll make recommendations, and then CMS will either agree, disagree, or say they're going to do something different. So when you look at those projects, when the reports come out and CMS says, we agree that this is something that we need to take a look at to monitor, then you may start to see where the RACs, the recovery audit contractors, start having those kinds of things that they're looking at, or that CMS, you start getting records requests for certain things. It's because the OIG has done these projects and studies on these things and have said, we found that, there's some problems here, and we need to kind of take a look at what these are. And CMS is saying, yeah, we agree, we really need to watch that to make sure that we're getting proper money back in the funds and keeping Medicare solvent for everybody. So then you want to also check the OIG work plan on a monthly basis for any new projects that may come out, because as I said now, and I showed you, that the OIG work plan does change and list different things on a monthly basis. So you got to keep an eye on it. It's not like it used to be before, where we could just put stuff out there and look at that once a year and kind of make our plans for the year. You really have to be going out there, or someone in the practice should be going out there on a monthly basis looking at these issues and making sure that the practice is staying right under the requirements for those things, and does not have to worry about getting records requests and things like that, or if they come, that you're confident in the responses that you're sending in to Medicare, that everything's okay. And also, of course, the OIG work plans, when they put these things out, they're kind of more geared toward Medicare and Medicaid and keeping those programs solvent, because they're for the HHS, and what they're putting out as the recommendations to CMS. But commercial payers, of course, are also seeing these things. And so it also, sometimes you'll start then getting requests from commercial payers, because they're saying that the OIG found an issue, and whether or not Medicare CMS is doing anything about the issue or not, commercial payors may take it and run with it and say, hey, the OIG found this. Let's take a look at it from our providers and our plans, and make sure that it's not a problem for us on the commercial side, where we could be doing some takebacks or things like that. So it's a lot to keep organized, and to have on your plate, looking at all these things. But you want to have and make sure that your practice is running compliantly and efficiently. And so you want to take a look at what's being looked at, to key in on those things, so it kind of gets you able to hone in on things, rather than just we have to look at everything, because that's just daunting and impossible. So this could kind of give you some ideas on where you want to focus when you're looking at things. So I'm looking in here, and if does anybody have any questions or comments for me? There's about a 10-second delay for these things, so if you do, I might not see it right away. So I'll give everybody a couple seconds. Okay, I am not seeing any. Hi, Christine. Thank you. I'm Christine just said thanks for the update. I'm glad that I can do it. So I appreciate everybody taking some time out to do this. Alrighty. All right. Well, since I don't see any comments, if y'all have any questions for me, please feel free to email me. Let me put up my contact information for you. So it's just scrolling at the bottom of the screen there. So you can email me if you have questions. Send me a message on LinkedIn. And I just wanted to tell everybody, normally I've been doing like every 2 weeks for my broadcasts. And the next broadcast would be November 19th, I believe, would be the 18th, let's see, 14, yeah. But the CPT symposium will be going on at that time, and I will be attending the CPT symposium. So I will not be doing a broadcast on that Thursday. I might do one on that Friday though, because depending on, what kind of things came up at the CPT symposium, because sometimes, you can get a heads up from the MACs that are there, and stating how they're looking at some of the new codes and what they're concerned about and things like that. So I probably will do one that Friday, just to kind of do like a recap of my take on the CPT symposium, to kind of get that out there for people before they start digging through the CPT changes books and all that fun stuff. Let me see here. I have a couple comments. Danielle, this was very helpful and informative just to even begin to know how to access this information and make it less daunting. Oh, thanks, Danielle. That's one of the reasons why I was glad to get approved to be a LinkedIn Live broadcaster, was so that I could do some of these things. Because I find in the field sometimes, especially for newer people in our field, is they have the educational background and they have that knowledge base, but when it comes to being on the job, boots on the ground, whatever you want to call it, in practice trying to get things done, sometimes it's hard to know where to look for stuff. You just don't know where to find things. And anything having to do with CMS, if you have to go to their website and try to find stuff, sometimes is next to impossible. Same thing with the Macs. Some Macs websites are set up very well. Others, you kind of really have to dig around to try to find what's going on, and it can be difficult. So that was one of the reasons why I started doing these, and I'm really, really glad to be able to give some information that makes people's jobs a little bit easier, which is why I also put those links in the comments, so you have the links to go to, so that you can go there, and then from there you can kind of start fishing around for things. Oh, hi, Carrie. You're welcome. I hope you're doing well. And Lydia, thank you. I'm glad you found it informative. All right. Well, then I will see everybody in a couple weeks to tell you what I thought of the CPT symposium. I'm sure it's going to be very interesting. Oh, and one more thing. In December, I'm going to be exhibiting at the NAMUS conference in Clearwater Beach in Florida, the medical auditing specialists association. So I'm real pleased. That's the first time I'm going to be exhibiting anywhere. It's something that I'm trying to, kind of broaden out a little bit, get the word out a little bit more. So on my LinkedIn account, I made a post about it, about going there with some information on the NAMUS conference. It's really geared toward medical auditors and compliance professionals. So anyone that's kind of interested in getting into that field or are in that field and are looking for it, it's one of the only conferences that's specifically geared to that niche. So check it out, check my post out. And it's NAMUS, NAMAS. You can also check them out. And if you go to the conference, please stop by my table and chat, and let me know if you've seen any of my broadcasts. And we do have the YouTube channel up and going. My graphics department is getting the past LinkedIn Live broadcasts that I've done loaded, and some other things onto the YouTube channel for Compliant Healthcare Solutions. So please check that out. If you miss one of the broadcasts but want to see it, you can check it out from the YouTube channel, or also look for it from your LinkedIn Live post if you signed up to attend. So a couple different ways you'll be able to repeat and watch the information. I have another comment here from Karen. Interesting. I'm doing a CDI work for Alaska, and they use the IHS. So thank you so much for the share. Oh, you're quite welcome, Karen. And good luck on your work that you're doing with them. So if anybody else has any issues or questions or comments or wants any help with anything, please feel free to visit the website or contact me through LinkedIn, and I'm always happy to help, and looking forward to bringing some more broadcasts to you. So everybody, I will see y'all in a couple weeks, and have a good rest of the day, and happy Baby Friday.